Welcome. My name is Nastasha Johnson, Associate Professor of Library Science at Purdue University Libraries. Welcome to tonight's event. I'd like to introduce you to our panelists for the evening. Dr. Charles E. Sanders serves on the Board of Directors of Mount Carmel Health System and chairs the board's Quality of Patient Safety Committee. MCHS is a 4-hospital system with over 80,000 employees. He was formerly the Vice President of Medical Education and Research for the system, where he was responsible for graduate medical education, research, and the underserved socioeconomically disadvantaged populations clinic. He also serves on the State of Ohio Medical Quality Foundation Board, having been appointed to the Governor of Ohio, by the Governor of Ohio. He received his BS in pharmacy from Purdue, his MD from Indiana University, and fellowship training in immunology and rheumatology at the University of Cincinnati. He previously was Vice President of Medical Education and Research at IU Health, Ball Memorial Hospital in Muncie, Indiana, Vice President of Research and Chief Academic Officer at the Call Foundation in Urbana, Illinois, and Medical Director of Immunology and Inflammatory Diseases Research Division at DuPont. He was also a practicing rheumatologist for many years. He has held faculty appointments at IU School of Medicine, the University of Illinois School of Medicine, Urbana-Champaign, and Associate Dean for Medical Education for affiliated programs for the Ohio State University School of Medicine. Dr. Sanders has been active for decades at various institutions in the care of underrepresented and socioeconomically disadvantaged populations. He has been involved in HIV and immunology research in the past as a fellow and over his career. Daniel López-Cevallos, PhD, MPH, is an associate professor of Latinx studies, ethnic studies, and health equity, and assistant vice provost for undergraduate education at Oregon State University. For well over a decade, he has worked towards addressing health equity issues, primarily among Latinx immigrant populations. His research focuses on the intersections of race and ethnicity, gender, class, and other socioeconomic and sociocultural factors, and their relationship to health and healthcare outcomes. Furthermore, he is invested in developing and implementing community, institutional, and policy level strategies to improve the health and well-being of Latinx and other marginalized communities. As a strong believer in the power of civic engagement, he has served as board member for a number of community-based organizations and currently serves in the Oregon Commission of Hispanic Affairs. Dr. Becky Good, DNP, FNP-BC, CNE, is a clinical associate professor of director of the Family Nurse Practitioner program at Purdue University School of Nursing.
Purdue training right now.
He has 25 years of nursing experience and has taught undergraduate and undergraduate curriculum since 2011. She maintains practice in family medicine and infectious diseases departments at IU Health Arnett. She is one of the first clinicians to focus on annual wellness visits, AWV, for the Medicare population and started a pre-exposure HIV prophylaxis, PrEP, clinic to improve HIV prevention in the greater Lafayette community. She has led numerous student research projects, and her interests include experiential learning, quality improvement, simulation, curricular development, and patient care access to vulnerable populations. For the next few minutes, we will discuss the COVID vaccine and what that looks like for underrepresented minorities and underserved populations. I'd like to turn it over now to Dr. Sanders.
Thank you, Dr. Johnson. I'm going to show my screen here, share my screen. Okay. Hopefully everyone can hear me and see my screen. Can everyone see my screen okay? All righty, perfect. So what I'm going to do today is just real quickly try to do it in 15 minutes, just kind of give you a brief update on where we are. And I'm having some trouble advancing. Oh, here we go. I'm just going to give you a brief update on where we are as of this date compared to March of 2020 in regards to the COVID-19 pandemic and the disease itself. Then I'm just going to talk briefly a little bit about vaccine development, because some of the hesitancy has to do with that. And then a little bit about the side effects. And then after that, I'm going to cover just a little bit of information on some of the factors that we are dealing with in regards to hesitancy of the vaccine administration in the African American community. So I put this slide up here because I actually gave this talk back in April 21st, 2020. And at that time, we only had about 40,000 deaths, which is quite a few, and only about 808,000 people were infected. But then you fast forward to this data, which is March 22nd, 2021, and you can see the huge difference from 800,000 infections in the US to 30 million, and a number of deaths from 44,000 to over 500,000. So we've had quite a trauma to this country. Everyone knows one of the main problems with this disease is its effects upon the lungs. And I'm not going to go into a lot of detail, but just I want you to understand that the problems that we have with this disease from a pulmonary standpoint, which has led to the majority of the deaths. So up in the left-hand corner is a normal chest X-ray, and a normal chest X-ray shows a lot of translucency of the lungs. The chest X-ray next to it shows a typical pneumonia with a little bit of what we call an infiltrate here. And then this, like the flu, will have a chest X-ray which shows a little less lucency. But with COVID-19, you have what we call in medicine a total whiteout of the lungs. And that's what results in folks being on respirators and going into respiratory failure and subsequent death. But that's not the whole story with COVID-19. And I think we need to talk about the whole story when we also talk about vaccine hesitancy. We've learned over this past year that COVID affects multiple organs. Early on, the previous administration talked about children may be immune. This is not true. And then when we're in the NCAAs, there's this issue about myocarditis in young athletes and also just in the general population. And now, after all the information we've got, we've also learned a lot about what we call long haulers. So real quickly, so we realize now after a year of studying this disease that there are a lot of what we call extrapulmonary manifestations of COVID-19. So not only does it affect your lungs, but it can also affect your brain, your kidneys, your liver, your gastrointestinal symptoms. We also know that there's a lot of blood clots associated with pulmonary embolus and deep venous thrombosis, and not just myocarditis of the heart, but all these other cardiac manifestations as well. We've also seen an increase in diabetes associated with the disease, and also a large number of dermatologic conditions associated with well. So it truly is a multi-system disorder. In terms of children, there's a condition known as multi-system inflammatory syndrome in children, MIS-C. It's relatively rare. The number of cases, the last time I looked, were about 3,000. And most folks will say that's not a lot of cases, but if it's your child, it doesn't matter. You know, one child is too many if it's your kid. But the interesting thing about this multi-system inflammatory syndrome in children, a large percentage of it, 69%, actually occurs in Latino or Black children. So it's something that we need to be aware of, and a reason why we need to wear our masks, get the vaccines, and make sure that we don't give this to our children as well as our adults. The other part of this clinical syndrome is myocarditis. And actually, this was first found back in August of 2020 at The Ohio State University, when they had a series of athletes who tested positive. And then a cardiologist actually did studies about 2 or 3 weeks out after they tested positive, and they thought they were ready to return to the athletic field. They found about 15% of patients who athletes who tested positive actually had this myocarditis, which was picked up by MRI exams. And now we all know that if an athlete tests positive for COVID, they're held out for about 14 days. And that's the reason why, because this myocarditis, if they re-enter the playing field too soon, they could end up with sudden cardiac death. And matter of fact, the first sentence on the slide says myocarditis is the leading cause of sudden cardiac death among athletes and may occur without any antecedent symptoms. And this is a slide I put down here about a young lady who played basketball at Vanderbilt. She developed myocarditis, and she subsequently had an MRI and found out that she did have the myocarditis. And her mom said that this MRI actually saved her kid's life. So this is truly a multi-system disease. But now what we've also started to deal with this disorder is the fact that we have these people who are called long haulers. And long haulers are individuals who either had symptomatic COVID, and we thought that they had recovered, but actually what they develop later on after about 2 to 3 months out is they can develop chronic fatigue, shortness of breath, persistent loss of taste and smell, intermittent fevers, heart palpitations, and it can affect their cognitive abilities, or what we call brain fog. So this truly is a multi-system disorder. And just because you have, quote, recovered doesn't mean you really have recovered. So we need to take that into account when we ask the question, should I get a vaccine or not get a vaccine? I put this together just to give you the complexity of when a person is infected with COVID, what do they look like? Well, they look like a lot of different things. A lot of patients get infected, they have no symptoms whatsoever. They have no organ damage. Others get mild illness where they can have complete recovery. They have some flu-like symptoms, but otherwise they do pretty well. Then we have others who have moderate illness where they get pretty sick, like the flu, but then they recover. But then we have individuals who get serious illness where they almost get hospitalized and they have some residual symptoms, the long hauler syndrome. And then we have those who are hospitalized and end up with long-term organ damage, like scarring in their lungs, cardiac abnormalities. And then of course, I've showed you already about the death part. And so, COVID has been very interesting in the sense that, you can't put it into a nice box, and folks can fit in multiple different categories. And the majority of the folks actually fit into the category of 1, 2, or 3. And I think that's where the misconception is in regards to, I get it, I get better, and I'm okay. And that's not necessarily true. So one of the things I do want to talk about, because that's what part of the panel is all about, is the fact that, even though 63% of the deaths actually occur in white Americans, Hispanics, Native Americans, and African Americans contribute to a large percentage of the hospitalizations when compared to white Americans. And I'm not going to read this slide. Other than the hospitalizations, if you look at African Americans, it's 2.9 times more than whites. Deaths are 1.9 times more than whites. And Native Americans and Hispanics are even greater than that. So it really has affected the communities of color a lot more than the white communities. A little bit about vaccine development, because I've talked to folks and they talk about the fact that I'm not taking the vaccine because they just came about this year, and we heard the term warp speed and all that kind of stuff. And just want to let you know that the vaccine development actually has been going on for a long period of time, and it just didn't happen this past year. So one of the things most people don't know is that we actually did have a similar COVID type illness known as SARS disease back in 2003, where COVID-1 actually transmitted from bats to humans. This occurred in Singapore and China. And then we had the MERS disease, Middle Eastern Respiratory Syndrome disease, in 2012, where a similar COVID virus transmitted from bats to camels to humans. So therefore, a variation of this disease has actually been in our past in 2003 and 2012. As a result of this knowledge, vaccine development was actually started back in 2003, accelerated in 2012. But what Saudi Arabia and China and Singapore did at that time, they instituted a lot of mask wearing, social distancing, hand washing, and a lot of public health issues, to the point that they pretty much controlled the disease. And so what then happened is that when you control a disease, then the vaccine development kind of not stopped, but it slowed down. So I put this at the end of the slide, is that the foundation for these current vaccines actually has been over the last 17 years. It has not just been over this past year. The other point I want to make too is that the HIV that started back in the 1980s, and I can remember that when I was a fellow at the University of Cincinnati, it actually has also helped lay the foundation for our current vaccines, because some of the vaccines that we've developed now, the messenger RNA vaccine, which is Pfizer and Moderna, and also the human adenovirus vaccine, which is the DNA vaccine, which is Jensen's or J&J, actually came out of the development of vaccines for HIV. So the vaccine platforms are actually not new. They've been around for a long period of time, dating back for coronavirus 17 years, but actually for HIV even prior to that period of time. I also want to give a shout out to Dr. Corbett, because when Dr. Fauci came out with this statement, a lot of people questioned whether or not this was true, but Dr. Corbett actually was very instrumental in the development of the Moderna vaccine. And back in March of 2020, when this was just getting started, the president had put together a council to look at this. And Dr. Corbett's team had already been involved in developing vaccines for coronavirus, looking at MERS and SARS that I showed you earlier, 6 to 7 years ago. And so when she was a part of this team, she actually made this statement, which I really liked back in March of 2020. She said, I like to call it the plug and play approach. But the basic idea is that we have so much knowledge based on previously done work by ourselves and other labs that they were able to, quote, pull the trigger quickly on this vaccine development and get the ball rolling in terms of phase 1 clinical trials within 2 weeks in March. So she had been working on this for about 6 to 7 years before this came on. The Saudi Arabians and China had been looking at it prior to that period of time. So the vaccine development did not just occur this past year. Now, the reason I put this slide up is because you'll hear a lot of people talk about the fact that the vaccine development takes anywhere from 8 to 10 years. Because of Dr. Corbett's work, a lot of this time frame was shrunk, and she did it over 7 years. Also, the phase 1, phase 2, and phase 3 trials were able to condense. And I will give the previous administration some kudos because of the fact that they actually streamlined the FDA approval process. And then the other part of this is when they put in the emergency use authorization and not took it to full approval, that eliminated another 1 to 2 years. So they actually compressed the process to develop this vaccine, and no steps were overlooked or shortened by any means. So the fact that they call it warp speed kind of threw some people off, but the vaccine development actually followed a very, very rigorous process. And I put this slide up here because we hear a lot about the vaccine effectiveness, and we can talk about this in the question and answer period. But there's multiple vaccines that are in the pipeline. We both know about Pfizer and Moderna at 95 and 94% effectiveness. The other vaccine that's on the market here is Johnson & Johnson, which is 66%. And then in the US, it's quoted to be 72%. And you're hearing a little bit about the AstraZeneca vaccine. This data is a little bit old. It's from November of 2020. And they're saying it's at 79%, but a lot of people are saying it's actually a little bit lower than that. Just quote quickly about the side effects. And I put this up here, and I know Dr. Good is going to talk more about this. But when you look at the side effect profile of all these vaccines that we currently have on the market, they've been relatively the same. And the top 2 side effects are injection site and fatigue. Otherwise, you get headaches, muscle pain, and chills. These are actually very common in any immune-based process. The interesting thing about this, though, is that if you look at vaccine administration worldwide, over 448 million doses have been given worldwide. That's more than the population of the US, which is about 331 million. In the US, we've had 124 million vaccine doses. So basically, majority of these vaccine doses have been either Pfizer or Moderna vaccines, and the safety profile has held up from the beginning of the clinical trials back in March of 2020 up until now. And so when you look at this, you look at the large amount of vaccines that have been given and the profile, you can tell that the profile really has not changed. So that speaks to the efficacy and the safety of these vaccines. Now, I've given you a lot of information about the disease itself, how severe it is, long haulers and involvement of kids and athletes. We talked a little bit about vaccine safety and the vaccine development process. But despite that, we still see a lot of hesitancy. And the question is why? And, this is just something that I put together, and it's sort of my opinion on this issue. In the African-American community, vaccine hesitancy is relatively complicated. And like I said, it's deeper than what we think. And so I'm just going to go through a lot of slides real quickly, and then we can have more discussion in the question and answer session. One of the things we do know, however, that within our community, and this is a slide that actually from April of 2020 by Pew Research, shows that African Americans do have lower confidence in scientists than white Americans and Hispanics at about 21%. But it gets a little bit deeper than that. It's not just Black people in general, okay? But if you break it down into age and you also break it down into healthcare system versus physicians, you can see that as in terms of healthcare systems, Black Americans have less faith in healthcare systems than they do physicians or their own doctor. And then as you look at it, it improves as we get older. And so a lot of the hesitancy is in the younger generation and a lot of the less hesitancy is in the older generation. But the takeaway point of this slide is that it seems that we have a concern about faith in the healthcare system itself, and our care and our trust in our physicians seems to grow with age. The other thing is this truly an African-American issue or is this an American issue? And I put this slide up, which is already outdated from April 2020 in the Pew Research Center. And in this slide, I'll just point one thing out. And down here it says, would you get the vaccine back in April? 54% of African-Americans said they probably would. White Americans and Hispanics said they would get it at 74%. We now know that the African-American statistics actually increased. Percentage for whites and Hispanics have actually decreased. The other thing is that if you look at this slide, which just came out in March, we can see that there's a little bit of a partisan issue here. And we know that a lot of African Americans are Democrats and there are some who are Republicans and independents. But when you look at the slide, you can see that those who are associated with the Democratic Party are about 90% likely to get the vaccine. Republican Party is less than 60% and independents that are about 60%. So there's a lot going on here, and it's not just necessarily racial, but I think it's a lot more than that. The other thing, when you look at this slide, particularly the bottom part of the slide, the one question that was asked is, do you believe that medical research, there's misconduct? And the one thing I want to point out is that most Americans believe that the medical scientists have good intentions, but they believe the research system is broken. So that kind of feeds into that anti-vaccine mentality or anti-research mentality. And this is Black, white, and Hispanics. The last thing I want to say is just that among African Americans, you know, I've already shown the slide where we see for this proportion of deaths and hospitalizations. As of March the 7th, the slide is already outdated. Over 73,000 African Americans have died of this disease. But most African Americans know somebody who has been hospitalized or have died from COVID. Personally, my stepfather died of COVID. I've had my sister and my stepbrother hospitalized with COVID. So this slide really says a lot about the exposure that Black African Americans have had. So in closing, I'm going to just quickly go through this. So vaccine hesitancy in the Black community is really multifactorial. It's not just cultural and systemic, but it's also conscious and unconscious. And everybody, not everybody, but most people know about the effects of slavery on the psyche of African Americans. We all know about Tuskegee and the story of Henrietta Lacks, but I think there's more things that is reason for hesitancy. You know, what I call the "why do you care now" syndrome. You know, it's sort of like some friends of mine. You know, when I was younger, if I was dating a young lady and she just kind of blew me off, you know, and then all of a sudden she came back. You know, it was like, well, why are you interested in me now? Why do you care now? You're always a little skeptical. But also we know a lot about structural and systemic inequality and inequity, which the pandemic has shown. But there's also a basic, as I've shown you, an anti-American, a basic American anti-science bias and a basic American anti-education bias. There was a book written by Dr. John McWhorter called Sabotaging the Race. He was a linguistic professor at Columbia University. He wrote this book about 2000. He talked about the anti-education bias in the African-American community, which feeds into this. We've talked a little bit about association politics, but I think another part of this too is a lack of trust in the healthcare system, which I showed you on a previous slide. And then also the fact that most Americans believe that the healthcare research system is broken. And so there's an old saying that if in the Black community, there's an old saying that in the white community, if they get a cold, we get pneumonia. that's a little bit true also how we view things. So if there's distrust of the healthcare system by whites, just think if you're Black and you're thinking, well, you designed the system and you don't trust the system, why should I trust the system that you put into place? And so it's
Thank you so
really
much, Dr. Sanders.
Okay.
Thank you.
So I just have one other quick slide. It really comes down to two things: who or what do you trust? Trust. I'll put this up here and let everybody read it themselves, and then I'll leave you with this slide. W. Edward Deming is the father of quality evolution, and he's an engineer. And I love this slide. It says, "In God we trust. All others must bring data." And I think that's what we need to do in the Black community is look at the data. So thank you very much.
Thank you, Dr. Sanders. Dr. López-Cevallos.
Thank you, Dr. Johnson. And I want to thank too Karina Olaru, the director of the Latino Cultural Center, for the invitation, and to Renee Thomas and Yula Gaha for organizing this event. I appreciate the opportunity to share some of my thoughts and be on this panel with Dr. Sanders and Dr. Good as well. Let me share my screen. I also have a few slides that I wanted to share with you today. I'm going to take a slightly different angle, and I'm glad that Dr. Sanders provided us with some context for what I'll be sharing with you today. So let me start by providing sort of what I'm thinking about the context on the pandemic as we are today, in the situation we are in today, and what we have lived through this past year. And one, I think one concept that I want to make sure attendees walk out of my thoughts today is the contrasting between providing equal resources and supports versus equitable. And so this graph here shows the difference between providing equal resources to different communities, but then the equitable gets at the point where the communities that need more supports for historical and contemporary reasons, that they requires an equity lens, an equitable framework to address these challenges. And I think in the pandemic, when we are right now, and with the vaccination campaign included, I think it is part of this, an important concept to keep in mind and to discuss as we are tackling this phase of the pandemic and trying to get as many people as possible vaccinated. So to expand a little bit on this equity framework or lens is the need to move from moving upstream from the outcomes that we see. Dr. Sanders spoke about the morbidity and mortality consequences of the pandemic. There are behaviors attached to that. Certainly, we know of preventive measures like mask use and distancing and so forth, that the compliance or not of those behaviors then lead to morbidity and mortality. But there's also, not just in COVID, but more broadly in terms of health outcomes, the need to think about sort of these other layers, levels of the environments in which we live and work and play. Certainly through the pandemic, housing has been highlighted, particularly thinking about when somebody would be exposed or somebody that tested positive and needed to isolate, to quarantine, then we wouldn't have that ability to be able to do that. The spaces that the homes that people live in, that not having enough space to isolate, to quarantine. But also certainly, and I'll speak more about this, is the issues around social inequities, around race and ethnicity, and through this past summer, we saw refocusing and re-engaging around racial calls for racial justice and the issues around racial justice that continue to pervade our communities across the country. And ultimately, too, is that policies and programs sort of set the stage for everything else that happens downstream. And so we are to learn and to build better and to be better prepared the next time a pandemic like this happens, is that we need to think about our policies, our programming, our systems in place to be able to tackle such an event. And I'll add, when thinking about more of the system level approach, it is that we need to confront this. I mentioned the renewed calls for racial justice, racial equity over the past few months have to deal with these underlying unresolved issues that we as a society face. The map that you see to your right is a map of Brooklyn and policy in the 50s and 60s, but that has ripple effects to this day about housing opportunity, the ability to build intergenerational wealth, et cetera, et cetera. So it is a system of policies and practices, norms that structure opportunity and unfairly disadvantages some communities and unfairly advantages other communities. So through no fault of their own, entire communities are impacted disproportionately, and we see that in the pandemic. So I want you to keep this as a framework for what we see, sort of this patterning of disproportionate impacts across different communities in the United States. Let me add another thought here, is in that when we, necessarily applies to the issue at hand around vaccine hesitancy, is that if we, that we cannot just look at these issues from an individual level standpoint, or purely as a cultural issue. That we provide the example here of Latino, Latinx communities, but it applies to other communities as well, in that issues like living in low resource communities, low socioeconomic position, how the larger community understands certain groups. We are seeing these understands or doesn't understand, stigmatize, discriminates against certain populations. We're seeing this right now just over the past couple of weeks, particularly with our Asian American communities, in that set the stage for this institutional pattern of unequal treatment, and that contribute to health disparities. So if we are to fully understand, to fully capture the issues that we see, the disproportionate impacts, we must take into account these other layers, these other levels that helps us understand, and that gives us pointers to address the issues. So if we only look at from an individual or from a cultural lens, and even within cultural, in my courses, I've taught a migrant health class ever since I started teaching position. That's one of the constructs that we need to deconstruct, because culture is more than an individual or family level construct. So we need to understand it more broadly, and certainly at the community level, community societal level. Just as an example of more of a structural issue here, and when Dr. Sands mentioned about, one of the things that our healthcare system, the way that we provide healthcare in our country, is health insurance is one of those features, right? And right now, the current administration has extended the window for people to sign up for Medicaid through the ACA, that we, that sort of structures what kind of access and coverage you will have depending on your health insurance. If we had a system where be it a national health insurance system or a national healthcare system like the UK, for example, the health insurance or the lack of health insurance would be a non-issue. All right. And so certainly when we see these, we see the differences here by race and ethnicity in the coverage of healthcare insurance or the lack of insurance. When thinking about the patterning of the pandemic, it's important to think about, it's mentioned throughout this, the times that I've spoken about this issue over the past year or so, is the issue about overrepresentation in these quote unquote essential sectors of the economy. And so you see, for example, this is from the Urban Institute, a report from 2019, and just the share of Black and Latino workers in most essential industries, just an overrepresentation. And the report certainly focuses on Black and Latino, but we could see, for example, among the Asian American community, Filipino hospitality workers, for example, that would also be, again, overrepresented in those sectors of the economy in what we have deemed essential throughout the pandemic. And so that overrepresentation means overexposure. And we see as a consequence, the patterning of concern, one, and you see this graph from Pew from April of 2020, being concerned about getting COVID and requiring hospitalization. Think about two is the concern is part of is, if I get it, will I be able to access the hospital services? Will I be able? What kind of bill will I get at the end of this a hospital stay? And certainly, when you see that the lower half of that graph is that the concern grows as we move from middle to lower income families, and so. It is not only a racial or ethnic issue, but it is a socioeconomic issue. And I think throughout this pandemic, we haven't fully characterized even the pandemic along these intersections of race, ethnicity, gender, socioeconomic status. We kind of have a sense, but we haven't fully understood it and monitored it. We certainly see then that overrepresentation is spilling over to the number of cases, and this is just from yesterday from the CDC. To give you an example, in Oregon, where I'm at, the Latino population is about 13%, but makes up 26% of COVID cases. And I'd give you another examples of Washington and California as well. So an overrepresentation in cases, I think that's been pretty clear. One thing to think about though too is just the undercount in how many of all the cases. Only about 54% of cases we know data where race and ethnicity was available. So there's almost half we don't know race and ethnicity for all those cases. There is but from those that we know, we see an overrepresentation in cases. We see an overrepresentation in COVID-related deaths as well. And the one issue I wanted to point out, and this is from the COVID tracking project, that shows just how much what we record in terms of race and ethnicity data, but what we don't. So hospitalizations, for example, in Indiana, is not only in Indiana, but I wanted to give you a local example, does not report race data for hospitalizations. And when we look at ethnicity, it's a similar pattern, but you can see the difference of how many of cases, deaths, and tests we just don't know. But from what we know, for example, the Latino population being about 7% of the Indiana population make up about 10% of the cases. So again, an overrepresentation. However, and this has been pointed out elsewhere, there's an underrepresentation in COVID vaccinations. And so you can see, for example, that although African Americans in Indiana make up about 9% of the population 16 and over, so the population eligible or eventually eligible for the vaccine only make up about 5% of all vaccinations. And we sort of see a similar pattern here with Latino the Latino populations also being about 6% in that eligibility group, but only about 2%. Part of, I think, again, this is the data that we know that we have available, but we don't know, again, is these other layers or intersections of race, ethnicity, gender, socioeconomic status, right? So are we really targeting those populations that are overexposed and overrepresented both in cases and deaths? To give you an example of this, in terms of the space and vaccinations, this is in Texas. What we can see here is sort of a clustering of vaccination sites along this major highway 35, and there are very few vaccination sites closer to where Hispanic populations are located. And so, again, in terms of access, right? So I think what we need to keep, one of my core points would be for you all to think about, and we can expand on the discussion, is, are those, is it, how much we need to address issues around accessibility and the population being able to make an appointment? Do they have access to internet? Will they have transportation to get to and from vaccination sites and so forth? Dr. Sanders mentions this, so I want to spend too much time on this, but this is the fairly recent survey, and so it has changed over the past year. The perceptions around vaccinations, certainly for African Americans, but also for Latino populations, where a majority they will choose to be vaccinated. And perhaps on the Q&A, we can discuss more about the groups up here with less likely to be willing to get vaccinated. Finally, I would say that, and this comes from a report about 12 years old now, on the issues that when we need to tackle this pandemic and the next public health emergency, but also other more structural issues that we need to attend to, there's a number of initiatives there that I think resonate, and we can talk more, including community-based participatory approaches to the interventions, including rolling out of vaccines, but also larger issues like raising income, which the recent COVID relief package provides some support in that area, and then also the representation of racial and ethnic minorities in the health professions. And with that, I'll stop and come back for the Q&A. Thank you.
Thank you so much, Dr. López-Cevallos. Dr. Good? We can't hear you, Dr. Good, if you're speaking.
Sorry, I apologize. I am unmuted now. I apologize. Let me get my slides up. And I thank you, Dr. Johnson, and thank you for the other panelists. Hopefully I am able to share a few new things with you in my presentation. As Dr. Johnson mentioned, Dr. Sanders mentioned, the COVID dashboard from Johns Hopkins today shows the total numbers at 124 million cases and close to 3 million deaths globally. We are at 1 year this month from when the World Health Organization declared COVID-19 a pandemic. So we've had a lot of loss in 1 year. And in the US, we've had almost 30 million cases and over 500,000 deaths. Since January, the new cases have been declining with a dramatic decrease in the number of hospitalizations and deaths. However, we are seeing a slight uptick with spring break. We have 3 FDA-approved vaccines in the US, all with good efficacy. I actually heard a speaker say that anything over 50%, they were going to be really happy with. So we have Johnson & Johnson's vaccine at 66% efficacy, Pfizer 95%, and Moderna 94.5%. One of the benefits of the Johnson & Johnson vaccine is that it's a one and done. Pfizer and Moderna both require 2 doses spaced several weeks apart. Pfizer is approved for ages 16 and older. Johnson & Johnson and Moderna both are currently at 18 and older, but studies are ongoing. And as Dr. Sanders mentioned, both types of vaccines use novel technology, but they've actually been studied for years. And Dr. Sanders mentioned that this is the mRNA is one of the technologies that have been studied for HIV. It is also one of the technologies that have been studied for cancer therapeutics, and a lot of vaccines and therapeutics are in development. So while these are new types of vaccines and they are different from the conventional types of vaccines, none of these types of vaccines have any actual coronavirus in them, which makes them safer. And I'll talk a little bit more about the differences, but just to give you some information on the type of vaccines, Johnson & Johnson is classified as a viral vector vaccine that uses a harmless version of the virus to tell our cells to make spike proteins, which are on the end of the coronavirus. And this causes the immune system to generate antibodies, whereas the Pfizer and Moderna vaccines are messenger RNA or mRNA vaccines that sends a message to the body to make a replica spike protein, which then leads to a protective antibody response. And then once the body gets the message, the messenger actually is dissolved completely by the body. So there's no residual effects or lasting effects from the mRNA vaccines. So how has vaccine rollout been going? We've had 125 million doses that have been administered in the US since the start of the rollout in mid-December. We've actually exceeded the original goal to have 100 million shots by April, so we're doing pretty well. Some experts have estimated that in order for us to reach herd immunity, which I'm sure you've all heard a lot about, we need to be at 70 to 90% of the population that would need to become resistant to the coronavirus, either through vaccination or infection. So if we maintain our current pace, about half of Americans would at least be partially vaccinated around mid-May and nearly all by late July. But this is, of course, assuming that our supply lines are met and that vaccines are eventually able to go to children under 16 years of age. Dr. López-Cevallos shared the race ethnicity slide with you all, but just to kind of highlight some points on this slide as far as who's getting the vaccine, CDC surveillance still shows inequalities among racial and ethnic groups, with 66% white, 8.9% Latinos, 7.9% Blacks, 4.8% Asians, and 1.5% Native Americans who've received at least the first dose of the vaccine. In the age category, as we might expect, older Americans have a higher percent of vaccination due to the prioritization of the rollout in all of the states. The number of younger population should start to increase as states open eligibility. And females are receiving the vaccine more than males. Eligibility requirements do vary by state. I think this was also shared in the chat as I was kind of watching along, but Hoosiers, our state, currently we're providing vaccinations for anyone over 40, first line responders, and any high-risk persons. And I think the website is on the chat if you wanted to look up eligibility for our state. Hoosiers show similarities with national trends in terms of age and gender, but we do have more disparities among racial and ethnic groups compared to national trends. And although some minority groups have a low percentage of persons vaccinated, according to the statistics from the US Census Bureau at the beginning of the year, 66% of Asians and 47% of Latino groups reported wanting the vaccine. So this isn't accurately reflected in what is actually being administered. In the LGBTQ community, new data released this month from the Human Rights Campaign shows that 42% of LGBTQ adults say they are very likely to get the COVID-19 vaccine, which is higher than the 39% reported by the general population. But major differences exist across LGBTQ populations, with only 29% of Black LGBTQ adults, 32% of bisexual women, and 39% of Latino LGBTQ adults expressing similar feelings. Transgender people and transgender people of color are more likely to get vaccinated, with about half saying they are very likely to get vaccinated. A study from the Kaiser Family Foundation showed that Republicans and younger and middle-aged Americans were the most hesitant to receive the vaccine, followed closely by Black adults and those living in rural areas. And I think, again, this has similar statistics have been shared by the panelists. So what are some reasons for vaccine hesitancy? At the top of the list is the concern for possible side effects. A close second are people who plan to wait to see if the vaccines are safe. 28% felt that other people might need the vaccine more than them. And these numbers were followed by doubt and mistrust against the vaccines or the government, and persons feeling like they did not need the vaccine. So as a top concern, let's look at some of the most common vaccine reactions. In the mRNA vaccines, the most common reaction was pain at the injection site, followed by fatigue, headache, muscle or joint pain, fever, chills, nausea, or swelling. There were a higher rate of side effects after the second dose, which I'm sure many of you have heard. This is not unexpected and is actually a normal sign that the body is building protection against the virus. Side effects usually only last a day or two, and a person can take acetaminophen or ibuprofen if this occurs. Only 2% of people generally feel ill enough to limit activities. Persons with allergies to any component of the vaccine should not receive it. Severe allergic reactions to polyethylene glycol, or PEG, which is also known as Miralax, a laxative that treats constipation, could have an allergic reaction to the mRNA vaccine and should avoid it and instead be offered Johnson & Johnson's vaccine instead. Serious reactions like anaphylaxis is rare, and there's no evidence of vaccination-related deaths at this time. And so if you've had a history of a reaction, you would be observed at the vaccination clinic for 30 minutes versus the normal 15-minute wait time and all of the clinic staff epinephrine. The Johnson & Johnson vaccine has similar side effects, including pain at the injection site, headache, fatigue, muscle ache, nausea, fever, skin redness or swelling, and is showing a lower rate of side effects when compared with the mRNA vaccines. The number 2 reason for concern was vaccine safety. Of course, a lot of this, as Dr. Sanders mentioned, is due to the speed in which the vaccines arrived, which cut years off the process. While it's true that the COVID-19 vaccines have been developed at a much faster pace than is typical, that's arisen out of the urgency of the healthcare crisis and not because of shortcuts in the process. The clinical trials have been held to the same rigorous scientific standards, and if anything, the transparency, scrutiny, and oversight over these vaccinations has been even greater for vaccinations in the past. And Moderna had over 30,000 participants in their clinical trials, and Pfizer had over 40,000. And again, while the mRNA vaccines are novel, as we mentioned, the technology has been studied for over a decade with other viruses, HIV vaccinations, cancer therapeutics. And so it already laid the background work, which made the design of this vaccine progress much faster. The newer technology also allows for faster development and scale up of the COVID-19 vaccine when compared with the conventional vaccines. And in the design of the COVID vaccines, none, like I mentioned earlier, contain the COVID-19 virus, so they won't make you sick with COVID. And the vaccine doesn't enter the nucleus of the cell, so it cannot alter or interact with our DNA. And additionally, over 100 million doses have already been administered, and the US has a robust system in place to track any adverse effects. The process to vaccinate people started off slow, but is picking up. And we have many efforts underway to focus outreach and reduce barriers to access. Certainly more is needed, but I do see this growing. Vaccination clinics are popping up all across the nation in hospitals, federally qualified healthcare centers, pharmacies, and in community buildings. And to sort of respond to what Dr. Sanders mentioned earlier, I actually did see it in coming to one of the churches in our community here in Lafayette. Most states also have a hotline for persons without access to computers, smartphones, or the internet, so that they're able to call in and schedule an appointment. I saw this in the chat as well, so I do have that here. You can call 211. That's the phone number if you don't have access to an internet or a computer or a smartphone, and you can register at ourshot.in.gov. And then I think there's actually 2 websites that you can go to. It actually takes you to the same place, 2 different links, and that was also posted in the chat as well. You can also, on a nationwide level, so that's in Indiana, but on a nationwide level, you can go to vaccinefinder.org, or you can go to goodrx.com/COVID-19 / where to get COVID-19 vaccines. So those are some ways to find vaccination clinics near you. Web pages have also been, and the Indiana web page uses this, a Google Translate at the very bottom of the web page that will help prevent any language barriers. And some areas are offering free transportation to vaccination clinics. And again, I think I saw that posted in the chat. So there's the number. IU Health here in our community will provide rides to any clinic. You don't have to necessarily go just to IU Health. They also have a language line so that they'll help you with translation if needed. And some states are doing a better job than others of promoting vaccine access, as we mentioned. And many are actually starting to open eligibility for persons 16 and older. And so on this screen, you can see sort of the states and what's open for eligibility. As of this week, 4 states, Alaska, Mississippi, West Virginia, and Arizona, have all opened eligibility to all persons 16 and older, and several more states will be heading that way very soon, as you can see in the dark purple. Indiana will actually be opening up access to all age groups over 16 on March 31st. So that's right around the corner where we won't have age limits here in our state. And as we know, there are many variations among the states in terms of the number of vaccinations received state to state, who's getting it, what access looks like. Some reasons for this have been attributed to the supply and demand for the vaccine, hesitancy in receiving the vaccine, and lags in data reporting. Currently, there are higher percentages of Americans in the southern and western states that do not want the vaccine, and the lowest numbers by state are displayed in the light green. The CDC continues to encourage ongoing safety measures to slow the spread of the virus, including wearing a mask over your nose and mouth in public for everyone 2 years and older, distancing, avoiding crowds in poorly ventilated spaces, hand washing, cleaning and disinfecting, getting vaccinated when eligible, and quarantining if symptoms develop. And I think we all know those sort of safety measures. But once you are fully vaccinated, which is 2 weeks from your final shot, you can start doing some of these things safely again, like gathering indoors without a mask with others who are fully vaccinated, and you no longer need to quarantine or test if you're exposed to the virus unless you become symptomatic. And so these very recent guidelines were posted by the CDC on sort of safety measures for vaccinated persons. So what have we learned in the past year? We certainly know more things than we did, but we certainly have more things to learn going forward. We know that the vaccines are effective against COVID, and hospitalizations and deaths are decreasing. We know that early data shows vaccine effectiveness against some variants, but we don't know about all of the variants. We know that safety measures help stop the spread of the virus and are still important. Early data also shows that vaccines may help keep people from spreading the virus to others. And we're still learning how long the vaccines will protect people. So booster vaccines may be necessary and are being evaluated. And just to conclude, I think it's important, especially tonight with the focus on diversity in this group, that we do celebrate our diversity and strengths, especially this past year that has been so hard in so many ways. And I would certainly be remiss tonight if I didn't just let our Asian brother and sisters know that we see them, that we support them at this time. And whatever our stance is on the vaccination, just to remember that unity is powerful and we must move forward together. Thank you.
Thank you so much, Dr. Good. I'd like to take a moment to thank you all of our panelists for joining us tonight. This event is in collaboration with the Black Cultural Center. Sorry, my video is off. In collaboration with the Black Cultural Center, the Latino Cultural Center, the LGBTQ Center, and it is also being co-sponsored by the Purdue University Library School of Information Studies. So I didn't do that in the beginning, and I don't want anybody fussing at me. So I want to thank you all, the panelists, as well as the collaboration with the centers across campus. Do we have any questions? I have some questions that we pulled from the chat. Does anyone, Karina Aluru, who's one of our director of the Latino Cultural Center, I saw your hand up. Do you want the floor? No. Okay.
No, I do not.
Okay, thank you, Karina. I wanted to honor you. I saw your hand.
No, there are questions in the chat though, so if you want to scroll through those and ask those, that would be great.
Okay, thank you so much, Karina. So the title of tonight's presentation is We've Been Here Before. Right, we've been here before. We know about some of the skepticism and hesitancy amongst the groups that we're talking about tonight, and some of the people represented in the audience. As an information professional, one of my areas of interest is the access to trusted information. What is one point of misinformation or disinformation that you like to cast down in this presentation tonight, or refute in this presentation tonight? There's a lot of it swirling around about the vaccine and about COVID, but I'd like to ask our panelists, what's one thing that if you could shoot it down, what would you do? And what would you say? If someone's speaking, you're muted, so. Dr. Good, what is one thing that you'd like to refute tonight for our audience?
That's definitely a tough question, and I tried to maybe integrate that somewhat in my presentation, but I've seen a lot of people on Facebook posting about the vaccine and questioning the safety of it and just how fast the rollout was, and thinking that maybe there's something not right about it, and so I guess that's one thing just that I would stress, and I feel like I probably already did in my talk, was that that this has been decades worth of groundwork that has been laid in order for us to have this vaccine so quickly. It just, everything fell into place. Now, they have been looking at mRNA vaccines, as Dr. Sanders and I both mentioned, for HIV vaccines, and for those it didn't work, but it is working for coronavirus. And, the ability to have that vaccine because of decades of work from scientists, I think it should alleviate some doubt and fear and mistrust in, they just rushed that science just kind of rushed this all together, and that people have a lot of reservations. I think that, this is really going to launch mRNA vaccines into the future, and that, we'll see a lot of benefit from this, because the conventional vaccines are attenuated, meaning that that in some of those vaccines, they give you a little bit of virus to stimulate your immune system to make antibodies. And in this case, that's not happening. You're not getting any of the virus at all. So I think for me, it seems less dangerous, and that there is increased safety in that. So I guess for me, that would be my answer. Thank you.
Thank you, Dr. Good. Dr.
And I would,
excuse me, Dr. Continue.
Thank you. I would two thoughts to that. One, I think it is important to not, the most recent, certainly the perceptions have changed, have shifted. The most recent poll suggests, a majority of the U.S. population is willing to get vaccinated. And I think that it speaks to, I think, the consistent messaging across different levels of government, that having trusted organizations, trusted members of the community, being vocal about the issues that we discussed today. So to having that conversation, so that those questions can be addressed. There's a lot of misinformation, and certainly because we have been connecting remotely, there are very few opportunities to gather together in person, right? With trusted leaders, with trusted community organizations. But I think that, so there's still, I think that quite a bit that will need to be continued to tackle, continue to address, because those things continue to happen. In fact, just earlier today, I had to field a question about the potential consequences, reproductive health consequences of getting the COVID vaccine, which there's no evidence to that, but there is an information that it keeps popping up. But I think there's that. And then two, I think it is more from a systems perspective, is that the accessibility issues, the ability to partner with communities. I saw in the chat, I think Karina mentioned the partnership with community-based organization to get the vaccines where communities are. So to bridge those gaps and those barriers that systems have had in place. One thing, though, that I think I see on the chat, thinking of barriers, is the need for providing a documentation when getting the vaccine. That can be a barrier, particularly for undocumented individuals in our community. So that what's the need? I would at least ask what's the need for that. But more broadly speaking, is it for systems to make every effort possible to get vaccines where those communities are? So be it the school-based healthcare centers, to reaching workers at their job sites to get vaccinated. So the more we do that, I think from a systems level perspective, the more we'll see reaching the communities most heavily impacted by the pandemic.
Thank you, Doctor. Dr. Sanders, do you have a reply?
Yeah, just one thing. I would say trust the science behind the vaccine. Trust the science behind the efficacy, the side effect, and the development of it. I put up that last slide about "In God We Trust" and all of them must bring data. Deming was an engineer, and Purdue's a big engineering school. And so the science behind the vaccines is solid. So I've been involved in research in my entire career. And, with science and data, you can't, you can fudge the data a little bit and all that is what people talk about. But the science is pretty clear after a year of information and data. So I would just say, trust the science. And the other thing I would say to African Americans in particular, I remember when I gave this talk back in April, before the vaccines had come out, a lot of folks had said to me, do you trust the people who are actually doing the work behind the vaccine? And I think, the reason I put up Dr. Corbett's picture is not only Dr. Corbett, but the Dean of Meharry's Medical College is also involved in the Data Safety Monitoring Board. There's other African Americans who've been involved in this process who we've just not seen. There was a picture of Dr. Corbett's laboratory. She had several African Americans working in the lab. Hispanics, Asians, the LGBT community have all been a part of this. And so trust the science. The science is no longer just the purview of one group of folks. There's a lot of diversity behind this. So I would say trust the science.
Thank you. One of the questions that we have, I believe, Dr. López-Cevallos, I think you mentioned this a little bit. One of the questions is, are pregnant women prioritized to receive the vaccine? And could that contribute to the difference in the number of women versus men who've been vaccinated?
I don't know if Dr. Wood would like to answer that question. I think that was one of the points in your presentation.
Okay, thank you.
And I'm happy to add to that.
Sure. Yes. So pregnant women are one of the specific groups that are eligible for vaccination currently. And for that group of women, I'm not sure if that's really raising the numbers for vaccinations, because another poll said that men have more hesitancy. But I would recommend that a pregnant woman who would like to be vaccinated to make sure that they talk to their OBGYN first, to make sure that they're getting the vaccination in the correct trimester, in which case that it would be most safe for the baby. As of right now, we don't have a lot of longitudinal studies on pregnant women. So there are safer trimesters in which you should get vaccines. And again, I would work with your OBGYN, similar to any vaccine that one might get in pregnancy. Thanks.
Thank you. Thank you.
Help?
Dr. López-Cevallos?
And I just added, I think I concur with Dr. Good, and I just added a side just with some more information from Johns Hopkins about questions about vaccine and pregnancy. So I think that will help to expand upon that.
Thank you. Another question. How have lessons from and impacts of the HIV/AIDS pandemic influenced hesitancy and or confidence in the science behind the COVID-19 vaccine? I'll open the floor.
Can you repeat the question? Just to make sure I got it right.
Okay. How have lessons from and impacts of the HIV/AIDS pandemic influenced the hesitancy and or confidence in the science behind the COVID-19 vaccine?
That's an interesting question. So how has the development caused hesitancy?
Basically, what are the lessons? What are the lessons and the impacts of the HIV experience and what we experienced during that pandemic? How have they influenced the hesitancy for this particular pandemic? So what did we learn? What was the impacts of the
I wouldn't say so much a hesitancy. I think there's a lot of lessons that we didn't learn from the HIV pandemic. And let's go back. So I was a fellow when HIV first came out in the 80s. And I can remember at that time, we thought it was just a disease in homosexual males. And since that time, it spread throughout the African-American community. I think some of the lessons learned is we really didn't have, and we still don't have, in my opinion, put enough emphasis on public health. And I also think, this brings back the issue that one of my panelists talked about, is the advent of the national health insurance. And so you have communities that suffered from HIV because of a lack of access and a lack of health insurance. And so you fast forward to today, and with this pandemic, we still have the same issue. And I think that has caused problems. In regards to hesitancy, I don't think that has been so much of an issue, because I think for the Black community, and I don't want to speak as a whole, but I think there's been a little bit of a hesitancy because it's been let me wait and see. The HIV vaccine, as Dr. Good talked about, it was an mRNA vaccine that it wasn't as efficacious as folks thought it would be. It didn't really work. And so I think some people looked at that and said, well, it failed in that population, but it fell in this population because the HIV virus was a messenger RNA virus, not realizing that it's a totally different virus. So I think that caused a little hesitancy. But I also had a lot of people who said, I'm going to wait and see. But as the numbers improved in regards to people getting them and getting the vaccine without side effects, I think that eliminated a lot of hesitancy. And so that would be my answer. I think one, public health. We didn't really learn the lesson in public health. We need to fund those. We didn't really learn the lesson of access. We didn't learn the lesson that this affects more communities than others, because as HIV left the homosexual white male population and went to the Black community suffered from that. So we really didn't learn that lesson. And I don't know if it fed into the hesitancy so much as it just fed into that we've been here before, that type of attitude. So that would be my response.
I would wholeheartedly agree. I have worked in infectious diseases, kind of back and forth now with my faculty role. I go in and out of infectious diseases and family medicine, but started in that department back in the late 90s. And I would wholeheartedly agree. People shied away from it. It wasn't as talked about. There was heavy stigma. And, I think we didn't have an infrastructure of public health. We, didn't sort of put it on the forefront for research and funding. And, fortunately, I think, 30 years, we're more than 30 years out from, the 80s when HIV first came about. And hopefully we've learned from our mistakes. And I think we have done a better job getting the funding out there, getting research. There have been private donations that have gone towards the vaccination campaign. And so I think that, again, that's helped the rollout come so quickly because everybody pretty much stopped what they were doing a year ago. I know because Eli Lilly is here in our state in Indianapolis, they pretty much shut down many of their projects that weren't absolute priorities to focus on COVID research. And so my assumption being, because I know Eli Lilly, that other pharmaceutical companies did the same, and scientists really just poured the focus into finding prevention and cures for COVID, which we didn't do in the 80s for HIV. Of course, that virus is completely different. HIV, and that's not the subject of this talk, but it's a very different virus. It's been very, very difficult to find cures for and to find vaccines for. We've done a lot with treatment and prevention, but we don't have a vaccine yet just because of the complexities. But hopefully that helps answer the question. I think we hopefully are learning from our past mistakes and we're doing better.
Thank you so much, Dr. Good. Doctor, you have something, Doctor?
Yeah, I just wanted to add just a couple of thoughts, if I may. I think one thing to build on what my colleagues have said, it is about coming back to public health infrastructure and the resources that need to be committed to rebuild an infrastructure that hasn't been there, and so that has made it all the more challenging. I think that's one of the lessons from the HIV pandemic, but also today we know that we need to apply a sort of a multi-level, multi-layered approach to HIV prevention. And a key part of that is a meaningful involvement of local communities that will help shape social norms, building social capital. Part of what I think we talked about today is trust, community cohesion, because that will allow foster connections and those transmission of health messages can be more impactful. Certainly local leadership is important, both to have supportive local leadership and consistent communication across multiple levels, so the messaging is consistent in that point, but also local leadership that is supportive of other community entities, organizations, so that they are working in tandem. I think that's also an important lesson.
Thank you, Doctor. We have a few more questions to go, but we only have about 10 minutes or so to ask and answer these questions. So what we're going to do for the next few minutes is this: whoever answers first is your question, and then we're going to move on to the next question, just to make sure we get to as many questions as possible. Okay. All right. So the next question is, how would you recommend addressing vaccine hesitancy or working with people who are vaccine hesitant? How would you recommend addressing that?
Well, I'll go first because I dealt with this early on, and I'll just be really brief. I heard a talk from the London School of Medicine. A young lady was talking about the hesitancy in the communities of color in London, and she said something which I thought was really interesting. She says, just tell people the truth and tell them the facts, and then let them decide. And I think sometimes in our country we have a tendency to massage the data and change the message for whatever we want. And so when I gave this talk back in April, and we were talking about the vaccine, and I talked to a lot of Black churches. A lot of people in churches were not interested in taking the vaccine. And so my wife gave me some advice. I listened to my wife. She says, just tell them the facts. So I didn't try to convince anybody. I just laid out the disease, laid out what the vaccines were going to look like, what we knew about the side effects at that time. And I just told them the truth. And then I think the other thing is that we should not talk down to people. And I think the lady at the London School of Medicine talked about that a lot of times when we address communities of color, we act like they can't understand certain things that we say. And that's not true. So the mechanism of action of the possible Moderna vaccine, going to the Golgi apparatus and all that, and people appreciated that. So I would say transparency, directness, don't talk down to people, and present them with the facts, and then let them make their decisions.
Thank you so much. Next question. What are some concrete examples of how officials or professionals are planning to reach out to minority populations who are hesitant or unable to get the vaccine? So what are some concrete examples or about how officials are planning to reach out? The floor is open.
From what I can tell, I think that certainly getting the vaccine in more and more sites, trying to make it accessible in a variety of ways through pharmacies, through clinics, through community buildings. I think providing transportation was a huge one. If we can get people into the clinics, I would love to see some home visits, but I haven't read anything about that yet. Certainly trying to reduce the language barrier, trying to reduce any kind of financial barriers by making the vaccination free to everyone, regardless of insurance or immunization or immigration status, excuse me. And so I think that those are certainly efforts to try and make sure that we're able to get it to everyone and not just those who have the means to get the vaccine.
Thank you, I appreciate it. Dr. López-Cevallos, this next question is yours. Have leaders, medical professionals looked at underrepresented communities that have experience with pandemics for guidance or assistance in addressing vaccine hesitancy? And are there any examples?
I think there are experiences from both in the U.S. And elsewhere in the world about examples of working with underrepresented, minoritized, marginalized communities. I think we see. I think one of the I guess my critiques have been, I think we're doing better at it, is the sort of the lack of coordination necessarily, or the patchwork of approaches state by state. So when thinking about the lack of consistency, right, is that sometimes, the state and federal policy may not agree, so that mismatch will engender mistrust. And so why is it that they are not, those are not aligned? But certainly I think I want to pick up on what Dr. Good mentioned is in the making sure that we reach to as many people as possible, right? If we are to reach that level of or that goal of herd immunity, then we certainly must reach deep and wide to communities, regardless of socioeconomic documentation status, et cetera. We must reach and as Dr. Sanders mentioned, provide the information, the opportunity for individuals to make a decision, but ultimately it is our responsibility from a system standpoint to make sure that we are making every effort to reach to those communities. And then also, I think I'll add one more piece to that, in that we must remember that this is a global pandemic. And so our responsibility won't end necessarily the moment that our local communities reach that level, right, of high levels of immunization. That it is truly as a global pandemic, we also must be thinking, and I've seen the current administration taking steps in that regard to reach out globally and coordinate efforts, because ultimately the pandemic won't end until we make sure that a large segment of the global population is immunized.
Thank you so much, Doctor. We may be able to get to a couple more questions. Next question. Do you foresee a situation whereby we shall be required to take the vaccine every year as the flu shot? And what happens if I'm vaccinated and there's a new variant like the one in South Africa? Will I be required to get another shot? The floor is open.
Well, I'll start and please add on if any of you have more information. I think, there's a lot we still don't know, and certainly we suspect that there may be boosters that we need potentially yearly, like the flu vaccine. And if I'm thinking correctly, and I haven't really read anything about this, but I do know with the flu vaccine, so there are different strains of the flu vaccine that hit every year. And then, scientists and people who research vaccines, they actually try to predict next year's based off of past seasons. So that's how we get the flu vaccine every year, is based on our best guess as to what next year's will hold. And then, people in that industry will then create a vaccine that they think will work for the next season, and that's what's administered. So my thought is that is very likely what will happen with COVID-19 as we learn more and more about the variants. My guess is they will try and make vaccines that will potentially be given every year to cover those different variants based off of what they're seeing, and certainly that's ongoing, because we don't even really know what variants were covered with the 3 vaccines we have. Although so far, they are showing efficacy on several. So, it's kind of one of those stay tuned. But if either Dr. López-Cevallos or Dr. Sanders, if you have more current information, please share. I haven't seen anything other than that.
Yeah, I would agree with Dr. Good real quickly. She summed it up very well. Yeah, when you look at this as an immunologist, since it's a messenger RNA virus, it's probably going to require once or about one or every 2 years get a vaccine. But viruses mutate or they change. And so just like the influenza vaccine, they call it shifts and drifts. When that happens, you have to change the vaccine. So yeah, I look for it to be probably a yearly vaccine, because right now we do not know how long the vaccine immunity lasts. There's a lot of studies out there looking at that, but we don't know. So yeah, I agree with her comments. I think they're spot on.
Thank you. I'm going to try to squeeze in this last one, y'all. The status of the AstraZeneca vaccine in the US. What are the issues with this particular one? I think a lot of our audience would love to hear your answers, but it has to be a quick one.
Just a bit that I've heard, and it's part of the holdup for that vaccine, although it's approved in the European Union and elsewhere, is that there is some questions by the FDA on the data that they have submitted. So that's part of, they are going back to review some of the data that they have submitted. Mm-hmm.
Thank you. So it is 8:29 Eastern Standard Time. I want to thank our panelists. I want to thank our audience for sticking out and learning more about the COVID-19. And yes, we are, it seems like a familiar place, but it's also a brand new place. So thank you so much for sharing your time and your evening, and everybody have a good night. Thank you.